The heartbeat depends on a finely tuned electrical system, where every impulse starts, travels, and ends with precision. But when this rhythm is disrupted, the consequences can be life-threatening. That's where antiarrhythmic drugs come in. Antiarrhythmic drugs are commonly classified using a modified version of the von Williams system, first developed in the early 1970s. This system divides antiarrhythmics into four main classes based on their primary mechanism of action. Class 1 drugs block sodium channels. Class 2 are beta blockers. Class 3 primarily block potassium channels. And Class 4 are calcium channel blockers. This lecture will focus on the Class 4 agents, the calcium channel blockers or calcium antagonists. We will consider how they work, when we use them, and why they're important in managing cardiac arrhythmias. As their name suggests, calcium antagonists are a group of drugs that block the flow of calcium ions through calcium channels. They specifically target voltage-gated calcium channels, often abbreviated as VGCC, although the channels may also be called voltage-dependent calcium channels and abbreviated as VDCC. A voltage-gated channel is a large protein molecule that spans the cell membrane and has a variable channel or pore running through its centre. The pore can open or close in response to a change in membrane potential. Cells at rest have a negative membrane potential, which means that the inside surface of the membrane is more negatively charged than the outside. Also at rest, the concentration of free calcium ions inside a cell is kept very low, at nanomolar concentrations. As calcium ions in the extracellular space are present at over a millimolar, there is a steep calcium concentration gradient across the cell membrane, which favours calcium entry into the cell when a calcium channel opens. When the cell is stimulated, the membrane depolarizes. In other words, the inner membrane becomes more positively charged. The charge is sensed by the calcium channel, which undergoes a conformational change or a change in shape, which results in opening of the channel pore. Calcium ions are now able to fit in the pore and can pass freely through the channel to the inside of the cell. Calcium antagonists, or calcium channel blockers, bind to a region of the calcium channel that prevents it from functioning normally. So when the cell is stimulated, it depolarizes as normal, but it is harder for the calcium channel pore to open, so some of the channels that would normally open do not. This reduces the likelihood that calcium ions will pass through the channels to enter the cell. Any signalling pathways that rely on calcium entry through the voltage-gated channels for their activity are therefore inhibited. Before we dive into what this does in the heart, it would help to have a solid understanding of the ionic basis of cardiac action potentials. If you're not already familiar with this topic, you might want to watch my video on cardiac action potentials, where I walk through the ion channels and ion fluxes that shape the electrical activity in different parts of the heart. You'll find the link to that video in the description below. Feel free to pause here and come back when you're ready, or continue if you're already comfortable with those concepts. Calcium channels play a critical role during action potentials in cardiac myocytes or muscle cells. The primary channel involved is the L-type calcium channel, which contains the Cav 1.2 alpha 1 subunit. At rest, The membrane potential of cardiac muscle sits around minus 90 millivolts. The action potential begins with a rapid depolarization or upstroke caused by fast activating voltage-gated sodium channels. This depolarization opens voltage-gated calcium channels, which activate more slowly and remain open during the prolonged plateau phase of the action potential. The plateau ends when calcium influx is overtaken by potassium efflux, repolarizing the cell. Calcium entry during the action potential serves two critical functions. Firstly, it maintains depolarization during the action potential plateau. This ensures a long refractory period, during which the muscle cannot be prematurely re-excited, preventing the atria and ventricles from contracting between heartbeats. Calcium entry is also crucial for excitation-contraction coupling. As it enters, calcium ions trigger release of additional calcium from stores in the sarcoplasmic reticulum, producing a strong, coordinated contraction. By controlling the amount and timing of calcium entry, L-type channels directly determine the strength and efficiency of each heartbeat. When a calcium channel blocker is present, the action potential starts normally, with the rapid upstroke caused by sodium entry. But the depolarization is less effective at opening L-type calcium channels, so they contribute a smaller inward depolarizing current. As a result, the plateau phase is smaller and shorter, leading to reduced calcium influx into the cell. With less calcium entering, there is less calcium released from the sarcoplasmic reticulum, producing weaker contractions, a negative inotropic effect. The lower intracellular calcium load also makes the cell less prone to after depolarizations, abnormal calcium-dependent oscillations in membrane potential that can trigger arrhythmias. The shorter plateau means repolarization occurs sooner, shortening the refractory period. In working myocardium, this effect is modest, but in some settings it can help restore normal repolarization and prevent excessively prolonged action potentials that might otherwise promote arrhythmias. Overall, these effects decrease the likelihood of calcium-dependent triggered activity. This mechanism can be beneficial in rare calcium-driven ventricular tachycardias, such as those associated with after depolarizations. But most ventricular arrhythmias depend on sodium channels and are not treated with class 4 agents. Calcium channels play a very different role in action potentials at the sinoatrial and atrioventricular nodes. The L-type channel expressed in these regions contains the Cav 1.3 alpha-1 subunit, which activates at more negative membrane potentials than Cav 1.2. As the heart's pacemaker, sinoatrial node cells generate action potentials spontaneously. The atrioventricular node can take over as a pacemaker if needed, but normally acts as a relay station, controlling the rate of action potential conduction from the atria to the ventricles. Action potentials at the two nodes have similar properties. Between heartbeats, when the membrane potential reaches its most negative point, it begins to depolarize again. This is known as the pacemaker potential because its slope determines the rate at which action potentials are generated. L-type calcium channels start to open toward the end of the pacemaker potential, contributing inward current that accelerates the late phase of diastolic depolarization. They open more fully as the membrane approaches threshold. Nodal cells lack fast sodium channels, so the threshold for firing is set by the voltage at which L-type channels open. Calcium entry through these channels mediates the upstroke of the action potential, and the rate of rise of this upstroke determines the speed of conduction between nodal cells. The membrane repolarizes when potassium efflux exceeds calcium influx. When a calcium antagonist is present, depolarization is less effective at opening L-type calcium channels, reducing calcium entry. As a result, it takes longer for the membrane potential to reach threshold, so the pacemaker potential is prolonged. This reduces automaticity, the rate of spontaneous depolarization in the sinoatrial node. The upstroke of the action potential becomes slower and reaches a smaller peak amplitude, because there is less calcium ion influx during depolarization. This slows conduction between cells in nodal tissue, which is especially important in the atrioventricular node, where it delays conduction from the atria to the ventricles. A characteristic feature of calcium antagonists is that they show use dependence, sometimes called frequency or rate dependence. That means the drugs block calcium channels more strongly as the channels are activated or used more often. For example, during rapid action potential firing in a cardiac arrhythmia. This trace shows cardiac action potentials firing at a normal rate. When a calcium antagonist is added, it produces only a small effect. However, when the rate of action potential firing increases, the block accumulates, so that in the steady state, the degree of block increases with firing rate. The effect is reversible. When the rate of firing returns to normal, the block decreases back to its low baseline level. Use dependence occurs because calcium antagonists have a higher affinity for calcium channels after they have been activated. When the cell is at rest, L-type calcium channels are closed and the drug's binding site lies hidden within the channel pore. When the membrane depolarizes, the channels open, revealing the binding site and allowing the calcium antagonist to enter and bind. Watch the animation on the left. As the channel gate opens, calcium ions flow freely through. While the channel is open, a calcium antagonist molecule can enter and bind to its site inside the pore, impeding the flow of ions. The drug can also dissociate while the channel remains open, so ion flow resumes when the molecule unbinds. If depolarization is maintained, L-type channels gradually enter an inactivated state and remain that way until the membrane repolarizes. Calcium antagonists also have affinity for this inactivated conformation and can remain bound, stabilizing the channel in the inactivated state and preventing it from reopening quickly. In nodal tissue, where L-type calcium channels drive depolarization, this use-dependent block becomes especially important. During tachyarrhythmias, when channels open and inactivate more frequently, more drug molecules can bind, producing stronger block. As a result, calcium antagonists selectively slow sinoatrial node firing and atrioventricular conduction when the heart rate is high, helping to control supraventricular arrhythmias without greatly affecting normal rhythm or contraction of the myocardium. The use dependence of a drug depends not only on which channel state it prefers, but also on its binding kinetics. how quickly it associates with and dissociates from the channel. In the animation on the left, you can see a blocker with fast kinetics. It attaches and detaches quickly, so it may enter, bind, and leave the channel before it closes. Because it unbinds readily between action potentials, the level of block doesn't build up much over time. This produces weak use dependence. In contrast, the animation on the right shows a blocker with slow kinetics. It binds more slowly, but once bound, it remains attached through multiple cycles of channel opening and closing during action potentials. With each activation, more channels accumulate in the blocked state. This produces strong use dependence. The block increases as the firing rate rises. So, even if two drugs have the same preference for binding to open or inactivated channels, their binding kinetics determine how effectively they can exploit use dependence. Class 4 antiarrhythmic drugs are used mainly for arrhythmias that depend on calcium channels in nodal tissue. These include supraventricular tachycardias, a broad term for any abnormally fast rhythm originating above the ventricles, such as those involving the atria or the atrioventricular node. In atrial fibrillation and atrial flutter, calcium channel blockers reduce the ventricular rate by limiting how many action potentials pass through the atrioventricular node, even if the atria continue to fibrillate. By slowing conduction through the atrioventricular node, they can also interrupt re-entrant circuits responsible for AV nodal re-entry tachycardia. Note that calcium channel blockers are not effective against arrhythmias originating below the atrioventricular node. That's because ventricular arrhythmias depend mainly on sodium channels. Two drugs define the class 4 antiarrhythmics, verapamil and diltiazem. Both block L-type calcium channels, but they differ in structure, kinetics, and selectivity, and those differences explain their slightly different clinical profiles. Verapamil, shown on the left, is a phenylalkylamine, while diltiazem on the right is a benzothiazepine. Their overall structures are quite different, but both contain a similar pharmacophore, an aromatic ring linked to a nitrogen atom, which allows them to interact with the same region of the calcium channel where their binding sites overlap. Verapamil binds most strongly when the channel is open or inactivated, whereas diltiazem has a higher affinity for the inactivated state and a lower affinity for open channels. Their binding kinetics also differ. Verapamil associates and dissociates more slowly, binding tightly and remaining attached for longer, while diltiazem binds and releases more rapidly. These differences in state-dependent binding and kinetics manifest as differences in use dependence. Verapamil shows strong use dependence, block becoming more pronounced at higher heart rates when channels open and inactivate more frequently. Diltiazem with faster kinetics produces a smoother block that varies less with heart rate. Both drugs slow conduction through the atrioventricular node and reduce automaticity in the sinoatrial node. However, because of its stronger use dependence, verapamil produces greater nodal suppression, often leading to a more noticeable slowing of heart rate. Diltiazem's effect is milder, which can make it easier to tolerate in some patients. Although their antiarrhythmic effects arise mainly from actions on nodal tissue, both drugs also reduce calcium entry into ventricular myocytes, decreasing the force of contraction. Verapamil has a stronger negative inotropic effect, so it must be used cautiously in patients with left ventricular dysfunction. Diltiazem's moderate inotropy makes it somewhat safer when cardiac function is borderline. Finally, both drugs cause vasodilation by blocking calcium entry into vascular smooth muscle. Diltiazem tends to produce a stronger vasodilator effect, helping to lower blood pressure, while verapamil's action is more cardioselective. Diltiazem may therefore be preferred when mild lowering of blood pressure is desirable. To conclude, Class 4 antiarrhythmics act by blocking L-type voltage-gated calcium channels, primarily affecting nodal conduction and myocardial contractility. They reduce automaticity at the sinoatrial node and conduction through the atrioventricular node, as well as reducing muscle contraction. Their effectiveness in tachyarrhythmias is amplified by use dependence, especially when binding kinetics are slow, allowing sustained channel block during rapid firing. Clinically, they're used for rate control in supraventricular arrhythmias. The available drugs are verapamil and diltiazem, which differ in potency and tolerability, with diltiazem often preferred in patients with borderline cardiac function.